How's everyone doing today? You can hear me in the back? Yes, very good. Nice to meet you all. Who likes to sleep? Yeah, me too. Yeah. Sleep always goes down when you go to a conference. The overall health of anyone's sleep. Today, over the next 20 minutes or so, 25 minutes, I want to share just two things. The first is why, from the lens of longevity, why sleep is so important. And the second thing that we'll look at is what is some kind of a strategy to help somebody improve it. From a educational standpoint, I'm an internist by training, did residency at UCLA. I love working in the intensive care unit, so I ended up doing a fellowship in pulmonary critical care medicine at Loma Linda, which is in California. And there's a big overlap between sleep apnea, which is a breathing problem during sleep, and pulmonary medicine. So I became really interested in sleep medicine through that avenue and ended up doing a sleep medicine fellowship in Boston at Harvard. And since then, I've been spending most of my time practicing sleep medicine, using everything that we've learned to date. And then I spend a little bit of time still in the intensive care unit, taking care of very sick people. I talked about the goals. Two things I want to really just sear into your minds. The relationship of what happens with bad sleep, and secondly, what are some strategies to fix that. If there's one slide when we talk about sleep and longevity, it's this one. On the y-axis here, we have the hazards ratio. On the x-axis, we have sleep duration. This is a study using about 322,000 individuals. Okay, so these are very large data sets. And what you can see is the likelihood of mortality goes up in people who are very short sleepers and people who are very long sleepers. Let that sort of sink in for a second. If someone is a short sleeper, they can't sleep more than 5 hours, if they're sleeping less than 5 hours, and if somebody is consistently sleeping more than 9 to 10 hours on a daily basis, their mortality is higher. This is not debatable. And that's a clue that something is wrong with one's sleep if they are biologically, if they have some kind of pathology and are a short sleeper or a very long sleeper. And this U-shaped relationship that I was referring to is true across almost all chronic diseases when it comes to its relationship with sleep. Hypertension, the prevalence of hypertension is higher in people who are short sleepers and long sleepers. Presumably for a pathologic reason, the prevalence of major depressive disorder is higher. The prevalence of anxiety is higher. The prevalence of cognitive impairment in the form of dementia is higher. And the same is true when we look at prediabetes or diabetes. If somebody is sleeping less than 4 hours, less than 5 hours, or more than 9 hours on a consistent basis, and they don't feel well, the likelihood of having all of these chronic conditions that we're all trying to fight is going to be higher. Okay, so that's I think the big thing, that if one understands that, then it becomes a much more easier conversation of saying, you know what, I actually want to improve my sleep. I'm investing all of this time and energy and resources in all of these different therapeutics that are available. But what I really need to also focus on is mitigating and de-risking myself from developing these chronic conditions through something very simple, such as sleep. You may have heard of the term, sleep is good medicine. Good sleep is good medicine. And this kind of alludes to that same idea. So how do we fix it? Have you guys heard of this? ESP-0911, Empower Sleep Peptide. 1 tablet nightly for 90 days. I'm just kidding. Fixing sleep is really hard. There's no magic pill, guys. I wish there was, but there really isn't. And, let me just take a step back. And if you think about, if you have knee pain, what do? Someone examines your knee, you do an x-ray, you do an MRI, and then you come up with a plan. So if somebody has sleep pain, or if somebody doesn't sleep well, what do? You get a sleep study. That's the first step in trying to figure out what is causing an issue with my sleep. The problem with sleep medicine today is it treats sleep issues like they're something static. Like anybody here wearing a wearable device? Got 90% of you all. So you can see when you come to a conference, your sleep is very different than when it was when you were at home. Imagine if you were a bad sleeper to begin with. You had a sleep disorder like insomnia, sleep apnea, restless legs, and now you're sleeping in a lab, hooked up head to toe, and you have one opportunity to figure out what's going on. Right? It just doesn't physiologically make any sense. It's one test, one night, sort of one result, one treatment. And I spent a whole year doing a sleep medicine fellowship in Boston, and all of that gets distilled down to this one slide, that you get diagnosed with something like sleep apnea, and you get prescribed something like a CPAP machine, or you get prescribed with, say, insomnia, and you end up with a sedative or a hypnotic. And we don't do that for any other specialty. Can you imagine if you went to your doctor, they said you have diabetes, and they automatically prescribe you insulin? That would be really crazy. If you went to your doctor, they said you have hypertension, and the same day they give you a list of medications. We talk about lifestyle, we talk about different kinds of medications. The same thing can be done in sleep medicine. I'm very inspired by wearable devices, glucose monitors. So we use that idea to say, okay, imagine if we took care of someone's sleep issue that way, where we did some kind of a measurement using a consumer grade or a medical grade device. We analyze that data. We did maybe 2 weeks of collection of data. We analyze that data. We understand this person's behaviors, their habits, their medical conditions, and then we intervene. We make some behavioral recommendations. We might make some prescription medication recommendations. We might try to understand what's going on, and then we optimize. And it's a continuously iterative process over time to help people improve their overall sleep health. And these sensors nowadays have been distilled down to something that can be done at home. And it's not just about the sleep study. We know that sleep is tangentially related to so many different things. Hormones, stress, anxiety. We have to have a good understanding of all of these things if we want to help somebody improve their sleep. And on top of that, everyone's sleep is different. If you look at enough sleep studies, how many of you are physicians here? So if you look at an x-ray of somebody, even though they may get diagnosed with, say, COPD or arthritis, the arthritis or COPD of each individual is different. Even if we're looking at the same joints. And similarly, when we're looking at someone's sleep, the fingerprint of everyone's sleep is different. So we need to approach it differently. And we need to do it on an individualized level where we get data about their sleep, we get data about their environment, we get data about their blood biomarkers, we get data about their mental health, and then we come up with a plan. And that plan needs to be done in such a way that it's unified. How many of you have a concierge medicine physician? A few of you. Once you have a concierge medicine physician, it's really hard to go back to a health system because you can't get a hold of anybody. You have questions and you want to know the same day. it's just the system is not conducive. So you need to have a team, and you need to have a team of like phenomenal clinicians who understand what's going on. They need to understand you as an individual, and that experience of care needs to be completely unified. So, if anyone's had a sleep study in a regular setting, it looks kind of like this. But if you have a multidisciplinary, unified care team approach who's looking at your data, who understands you as an individual, who understands your blood biomarkers, and understands your goals, you can have some really unique insights and some phenomenal outcomes in a very short period of time. So here's how it works. You'll get a sleep study. It looks like this. These sensors have been distilled down to something that goes on your finger, or a more comprehensive one that looks something like this. It's a self-applied home system. And you download an app, and you do a sleep study on a nightly basis. We look at that data daily. You meet with your doctor frequently, and we come up with a plan to then what to do over a period of time to get someone from bad sleep to healthy sleep. I get a lot of I was getting a lot of questions yesterday, so I just wanted to map this sort of out. You'll meet, the way that I think sleep medicine should be done is how we've sort of designed this. You spend a good hour and a half meeting with your physician. We'll start off with a sort of 2-week baseline assessment of someone's sleep. We'll try to figure out what's the root cause. What's the problem that is driving this person's sort of overall sleep health decline? And then we'll design structured experiments personalized to you. Okay, if you think that alcohol helps you have better sleep for whatever reason, then let's do an experiment. Let's test this out. Let's abstain from alcohol for 7 to 10 days and see what happens. If you think your sedative or hypnotic helps you improve your sleep, let's do an experiment. Let's do a week of testing with and a week of testing without. So now you can start to figure out what is driving healthy sleep in that individual and what is not driving healthy sleep in that individual. And that closed feedback loop system drives awareness for the doctor and the patient. Anybody here have a continuous glucose monitor or ever tried one? Most of you. It's mind-boggling how powerful it is to understand your physiology in real time. And when you do that, you get to understand your physiology as an N of 1 and then come up with a program that works for you. In our program, we see patients every 2 to 4 weeks. You'll have a call with the rest of the coaching team, and there's going to be ongoing frequent check-ins. So there's no magic pill to fixing the problem. And I'm just going to share some examples of what are the different solutions that exist when it comes to helping somebody improve their sleep. So let's say, for example, we have someone who has insomnia. And what I mean by insomnia is someone who has difficulty falling asleep, difficulty staying asleep, difficulty waking up earlier than they want to, and they have some level of dysfunction, brain fog, fatigue during the day. And, when it comes to something like insomnia, without getting into too much detail, all of these things are relevant. When did it start? How long has it been going on? What's the health of your sex hormones or metabolic hormones? Are you on, we've taken people off of beta blockers, for example, because beta blockers can cause insomnia in some individuals. So what medications are you on? Is there a role of polypharmacy that's playing that you are at risk of? Is there any nutritional deficiency? Is there stress? Is there mental health conditions? What is the driver of your inability to fall asleep or stay asleep? And once you have, and usually it's never one thing. Having been doing this long enough, it's usually not just one driver. It's usually, in medicine we use this term multifactorial, and I don't like using it, but sleep is one of those things that there are usually many drivers of why somebody doesn't sleep well. And then from a non-prescriptive solution standpoint, you have things like cognitive behavioral therapy, for insomnia. It's basically helping somebody. I was talking to a few people yesterday, and it's not uncommon for people to condition themselves to think that they're a bad sleeper. They wake up in the middle of the night. This problem has been going on for decades, and they have conditioned themselves that, guess, like, here we go again. Now I'm awake, and it's going to be hard for me to go back to sleep. Cognitive behavioral therapy is helping somebody restructure their thoughts around their sleep, around those awakenings, to help them get back to better sleep. There are a whole variety of sleep hygiene type of things that need to be implemented. Having consistency, abstaining from alcohol, abstaining from nicotine before bed. Then there are solutions that, you've heard of the autonomic nervous system. It's like our automatic nervous system. It sort of lives in a balance between a parasympathetic rest and digest state and a sympathetic fight or flight state. There are modalities through meditation, breathing exercises, through vagal nerve stimulation that can amplify or boost that parasympathetic rest and digest state. So those would be things that could be tried. And then acupuncture. These are all non-prescriptive solutions that could be used to improve someone's sleep. And then we have our traditional sedatives and hypnotics. And at least in our program, I don't prescribe anybody any sedative or hypnotic until they have tried these like conservative solutions. These sedatives and hypnotics, they can put people at risk of having cognitive decline in the future, excessive falls, hip fractures, and it can be a downward spiral. So I'm not a big fan of them. However, if with a sedative or a hypnotic, someone's sleep is better and their quality of life is better, then it's in discussion of like, hey, is this a risk that we want to take? Because your overall quality of life is important to me and important to you, and let's have an educated discussion around this. Let's say somebody has sleep apnea. Anybody have a sleep study here? About 20%. It's not uncommon to get diagnosed with sleep apnea. And the traditional model is anybody with sleep apnea gets prescribed a CPAP machine. It's unfortunate, but that's just how things are because they don't have the tools to track sleep across time. And not all sleep apnea, like not all arthritis is the same. Not all hypertension is the same. Not all diabetes is the same. Similarly, not all sleep apnea is the same. It depends on what's their underlying quality of sleep. What are the symptoms that they're having? How severe is it? Is it positional? Is it only on their back or is it on their side and their back? You've probably, whoever has a bed partner that snores, you probably have observed that when they switch over to their back, there might be more pauses in breathing and more snoring versus their side. So is just side sleeping, yeah, the elbow, right? Yeah. So, there's so much that goes on when someone is sleeping. So what stage of sleep is it happening in? How much hypoxia do they have when they sleep? What's the anatomy? Do they have a congested nose? Are they a mouth breather? So all of these things play a role in even understanding something like sleep apnea. And based on that, there are a whole host of different solutions that can be experimented with, ranging from, nose dilation, breathe right strips, mouth tape, chin straps, side sleeping pillows, incline. And these could be like this. I can say this comfortably on stage. Like I've taken people off of CPAP machines because these kinds of solutions resulted in better breathing and better sleep for that individual versus a CPAP machine. And there was better compliance. They had mild apnea to begin with, but the only reason I have that confidence is because I was tracking their sleep across time. If I had just done a single night study, I would not have been able to have that confidence to take someone off of something. And then there are many different prescriptive solutions ranging from, I was talking to Dr. Aman yesterday. There's a whole host of dental solutions that exist that can help somebody improve their anatomy and oral airway during sleep. And then if someone has restless legs, I won't sort of get into many of these things, but about 1/8 of you all has restless legs. An eighth of this group has sleep apnea, and an eighth of this group has chronic insomnia. That's 50. That's almost 50% of the group of the individuals in this room, and these are low-hanging. It is a very low-hanging opportunity to improve your health through the lens of just improving your sleep. And then we talk a lot about peptides, and there are many different peptides that exist. Delta sleep-inducing peptide, it modifies our sleep architecture, and it can improve deep sleep. There's one called CJC. It modifies our growth hormone. There is another one called epitalon. I was just talking to somebody outside. The way this works is by modifying our circadian rhythm system in the back on the pineal gland. And then there is some data that, oxytocin can help. So there's a whole host of peptides. There is a growing list of supplements. And we get to talk to people, and sometimes these are small lists, sometimes they're very long. But there's a whole list of supplements that can help somebody improve their sleep. But who was here for the Heads Up Health conversation? Anybody from this room? A few of you. Like, if you don't have the data, if one does not have the data, one cannot make an educated decision on what is working and what is not working. Whether it's an Oura Ring or a Whoop or a Garmin or a sleep study, we need objective evidence to figure out what works, what doesn't work, and then we also need the guidance of somebody so that you can do this fast. So this is kind of what patient journey looks like. In a usual model, you have a single night study, it labels you with something gets introduced, and may or may not get a follow-up study a few months out. The way that we have been thinking about this is like, let's get a baseline understanding of what's going on. Based on that baseline understanding, let's introduce an intervention. Okay, now what? Let's optimize that intervention. In this case, I'm just using the example of CPAP because sleep apnea is probably the strongest lever that can be fixed very easily. Start off with sleep testing, introduce a modality to treat sleep apnea, optimize that modality to treat sleep apnea, make some continue modifications, help them change their lifestyle from an alcohol, home lighting, wake up time, exercise standpoint. If there's still any residual symptoms, introduce a layer of light cognitive behavioral therapy and try to get people to better sleep in 90 days. I wish there was like an Empower Sleep peptide. I wouldn't be shopping at Costco anymore, but we don't have one. It's a iterative, continuous process. It's a journey to try to get someone into better sleep. Here's a couple of examples I wanted to show you that I thought were really interesting. We have about a minute, so I'll go a little bit faster. You see this purple line graph. So this is a 30-day window of sleep testing. Usually people get a 1-day window of sleep testing. This is a 30-day window of screenshots from the app. You can see this purple line graph is the sleep quality. You can see these peaks here. This was an example of someone who did really well with CBD. Here's an example of someone who did really poorly with altitude. Here's an example of someone who, was prescribed CPAP, with and without CPAP, this person's sleep is unchanged. Right? Like, that's kind of like many times we just assume that if you receive a CPAP machine, you're going to sleep better. You might get told, hey, you got to tough it out for 6 months and you will get better. But if you can see that there is no immediate change within a matter of a couple of days, like, something needs to be done. You can't just force someone to keep using the CPAP machine with the same mass, the same pressure, the same temperature, the same humidity for 6 months and then deciding what to do. Here's a really fun example of a patient that just happened to take their ring with them to a meditation retreat, and you can see like their sleep quality almost doubled during that time. So the use cases are, there's no quick fix, there's no magic pill, there's no magic peptide or exosome or stem cell. It's just an iterative process to understand your physiology, receive guidance from someone who knows what they're doing to get people to better sleep. And over the last 3 years, we've done over 600,000 hours of sleep testing. That's about 75,000 nights. We've seen some really phenomenal outcomes, and we've had the opportunity to partner with some world-class clinicians across the country to be able to do the things that we do. And sort of in summary, if you have bad sleep, you cannot have longevity. Period. If you have bad nutrition, poor exercise, poor mental health, poor sleep, one cannot have longevity. And the last thing is there's no golden pill to fix your sleep. It's a iterative process over time to take someone from where they are to where they want to get to. And I just want to shout out to the team that's here today. Without them, we wouldn't be able to do what we do. And yeah, if you guys have any questions, I know we're out of time, please ping me and the RAD clinic. I'm happy to answer any questions that you all might have. And we're always, just a quick shout out to the team who runs the social media channels. If you guys are always looking for tips and tricks, please follow us on social media. Thank you.